Yes.
Discuss him.
All right. So, good afternoon. With your permission, can I start the video? I'm Dr. Neeraj Israni, and let's start the video, please.
Presenting to you Spec Drape, a novel disposable speculum with eye drape. Post-operative endophthalmitis is the most dreaded complication for a cataract surgeon. Eyelid infections leading to contaminated surgical fields are the most common reasons for this. Improper draping, as seen here, is one of the leading causes for this. Hence, to put emphasis on proper eye draping, we need to first get rid of the conventional ways of eye draping. The steel speculum, on the other hand, is proven to cause eyelid tissue damage and lead to pain, ptosis, and difficult to put in deep set eyes. Thus, we had a research question so as to come up with a speculum and a drape combined to make it easier, faster, and patient friendly. Hence, we developed the Spec Drape, which has all the above features on a CAD file and 3D printed the first prototype. The Spec Drape not only has a draining outlet for the fluid but is extremely elastic and designed to completely cover the eyelashes. Here is a demo of the Spec Drape on a patient. This is the 3D printed prototype which is assembled with the adhesive skin part of the eye drape. The Spec Drape has an outlet which will drain the fluid into the pouch as seen over here. As you can see, once we strip off the plastic like any other eye drape, it is adhesive to the skin. Further, the inner ring will go and engage in the lower and the upper tarsal plate. And since this is a 3D printed device, the stretch is not enough, but ideally it will completely stretch and give a very wide field of surgery to the surgeon. This is the CAD file for the latest prototype, which consists of two parts which are joined together with the help of a screw. This screw will help us to increase or decrease the surgical field depending on the surgeon. Final autoclavable prototype is in works and will be available very soon. Thus, the advantages of the Spec Drape would be that it is less time consuming since it is a one-step procedure. It not only is a less cumbersome procedure for the patient, but also makes sure that the entire eyelashes are covered, thus reducing the chances of any infection.
Thank you. So, just wanted to add one more thing, that this is still in the 3D prototype stage. The final one will be made out of silicone and poly lining that will be very stretchable because of time constraint. We've spoken to a manufacturer also, and we are in works with other engineering students also, making it much more better. So, sir,
Because when you put the speculum, I saw that
yeah.
the eye, I mean, cornea was as if it was
I'll
inside
show
a
you
bed.
I'll show you the dimensions. Just can you?
And second thing, you said it is painless.
Sir, this will be
To use
painless
Spec Drape
because
prototype combined
just one
to
second.
make it.
Yeah, go back, please. So dimensions, it will be coming in, the diameter will be 22, 23, and 24, 25, 26. So depending on the surgeon's comfort, right now it will stretch up to almost, that diameter of the outer polyacetyl ring will be 58 mm, whereas the inner one will be in 4 or 5 dimensions from 22 to 27, and it will stretch up to completely that a normal eye speculum can give a surgical drape. In the latest one, we have a screw which we've come up with. So with the help of the screw, you can adjust it, and whatever is your comfort of surgical outfield, you can decide that also.
You said it's painless, right?
It will be painless because
No,
it will go inside the tarsal plate and just like a normal speculum.
No, but when you're extending any of the patient is going to, when it is stretched,
But
they
it
might.
is not stainless steel, so
No, but
stainless.
still, any material which is stretching can cause. And do you have anything for intravitreal injections? Because we come across more infections in injections than in the cataract surgery
So
nowadays.
this will be used for all, even for cataract surgeries, intravitreal. It will be universal, sir. And we are aiming at the same cost that a normal drape comes up to. So cost wise, also it will not be more than 50 or 60 rupees per drape. Right.
Third one. Thank you, Doctor.
Thank you.
I now request Dr. Shivraj to present his technique on NIST, and Dr. Parikshit will be the discussant.
Good morning, everyone. I'll be presenting on my topic, NIST NIST, that is needle incision subtenonous anesthesia. So, to begin with, as we all know, majority of our cataract surgeries are performed under some sort of local anesthesia, maybe topical anesthesia, subtenon anesthesia, and peribulbar anesthesia. So most of the phaco procedures nowadays are performed under topical anesthesia, but there are certain disadvantages associated with it, including it does not produce akinesia, and the pain sensitivity is not reduced when there is involvement of iris or ciliary body manipulations. Other thing is peribulbar anesthesia is also other good option to provide anesthesia, but it was found to be associated with chemosis and subconjunctival hemorrhage, and there was an also associated risk for globe perforation and retrobulbar hemorrhage. Another thing is that it has a slightly tougher learning curve because since it's a blind procedure. So subtenonous anesthesia is comparatively, the learning curve is less difficult than that of peribulbar anesthesia, and it can be a good alternative option, especially in phacoemulsive processes which involve complicated surgeries like hypermature or mature cataract, in cases of posterior polar cataract, and in patients having phacodonosis following a traumatic cataract. So our problem statement was not on subtenonous anesthesia, but the technique involving it, which in the conventional technique, which involves a conjunctival seizure and which is used to dissect the stenons and the conjunctival tissue. But the opening made by such blunt dissection using scissors is large, which accounts to many complications, like it can lead to chemosis, it can lead to subconjunctival hemorrhage. There is a large defect which can be a possible nidus for infection, and sometimes it's so big that you have to also apply a conjunctival suture. So we came up with this solution. So what was the basic problem is the blunt dissection provided by this conjunctival scissor had to be eliminated. So in order to reduce the existing complication associated with subtenonous anesthesia and reduce the volume of anesthetic agent used and avoid blunt tenons dissection, we came up with a instrument which like lacrimal dilator, which can be used to make a point entry, and we named it as NIST. Here's a video demonstrating the work of it. As you can see, it's a Wilder's lacrimal dilator size 3, which is just used to make a punch entry into the triangular space held by the forceps. And as you can see, just a single entry, and you can see a hole over there. And it goes into the dissects the conjunctival as well as the subtenonous tissue. And just we have to do is take the viscoelastic cannula into the subtenon space and inject the anesthetic drug. As you can see, injecting the drug, and kinesia is produced in this patient. So what is the advantage of this technique is that since we are avoiding the dissection, the blood vessels rupturing in this scenario is very less, which leads to less incidence of subconjunctival hemorrhage. Also, the point entry makes us possible to like localize an area which has less amount of blood vessels. Hence, we can also, all these things can basically decrease the subconjunctival hemorrhage associated with it. Also, the volume of, since the point opening just snugly fits into the lacrimal, that viscoelastic canal diameter, the amount of drug coming out is also less, due to which they have to inject less amount of drug, and it inadvertently leads to minimal rise of IOP in the situation. So this technique prevents the complication made by using dissection, which is a part of a conventional technique of subtenous anesthesia, while ensuring the quality of anesthesia. And the patient, the post-operative day one, will have clean white eye, which is very aesthetically pleasant to the patient. Thank you.
Last question. Very nice innovation. My only doubt is, since you're not dissecting the subtenon space, if there is a possibility that if you've not entered into the right plane, the anesthetic can go into the subconjunctival space rather than subtenon.
Yes, sir.
So has that happened in your cases? And
very rarely, sir.
how do you avoid it?
If we hold with plain forceps, if we hold the conjunctiva properly, it takes up both the conjunctival tissue as well as the subtenon tissue. And if we just make a stab entry into the tissue, and if you just hold the conjunctiva in a form of triangular space, both the tissues are dissected at the same time. But yes, there is a possibility of it going into the subconjunctival space, but what we saw, it was very less as compared to that.
But you have not documented it.
We have not made a comparative analysis, but as an observation of many patients, now we have completely shifted to this technique because of the less complications regarding.
Basically, instead of taking a small neck, you're
Yes,
doing a stab
and
through
yes,
and through.
Yes, sir. Stab and through and
So, in many ways, we give subtenons anesthesia so that there is no needle prick.
Yes, sir.
But then, isn't a stab also like a needle prick?
Yes, sir. The thing is, we don't direct the stab entry into the eye. We direct it quite
Slightly away.
parallel, or maybe even opposite to the direction of the eye.
And in which quadrant you make this stab?
Inferonasal quadrant.
It's always in the inferior.
Inferonasal, yes, sir.
Sure. Thank you, Dr. Bhajan.
Thank you, sir.
Thank you. Do we have Dr. Kiranjit Singh?
How many cc's were injected, Abhijit?
Sorry. I'm very sorry. There are two. I'm just, but I'm just following somebody's orders. But morning and yesterday, people were not allowed to present also. So,
Certificate is
No, but this is ARC. Dr. Chitra Ramurthy from
then do we have Dr. Anjali Sehgal? She's going to talk on a novel biodegradable safe personal protective equipment made of soap paper and gauze. And the Dr. Naren Shetty is here. No. So I think Dr. Santosh Bide, you can be discussant.
Should I start?
Please.
So, good afternoon, respected colleagues. And I've heard a lot of nice innovations, and I'm presenting mine. It's a medical environment innovation. We've recently got a patent for this. Sorry. We know that the world is deluged by plastic waste. It is non-biodegradable, so it is very harmful to the environment as well as to all forms of life. The COVID pandemic generated so much amount of plastic. It comes under single-use plastic. 8.4 million tons were produced, so much so that the plastic waste was itself termed a shadow pandemic. So our innovation is a PPE kit which replaces plastic PPE and is made of completely biodegradable soap paper, ecologically sustainable and extra safe, as I'll show you. The idea came from traveler soap booklets, which we take when we go on our travels to wash our hands. And it was only commercially available as small strips of paper. So initially we had to request a manufacturer to specially create a spool for us. The first prototype we made was very fragile. So then we made a double layer. Then we added gauze inside. So we kept working on it to make it more durable. Finally, we were able to achieve seam sealing. A lot of refinements were made on the paper thickness, viscosity, perfume, etc. And our objective was to make it safe for medical and other use and to make it wearable. This is the current prototype, which has 3 layers. There's an outer layer of paper coated with an inner lining of soap and innermost cotton lining. It has many advantages. Unlike plastic PPE, which is non-biodegradable, this is hugely biodegradable. Apart from providing just a physical barrier, as we know, soap is virucidal not only to the COVID virus, but even the common viruses that the anesthetists keep asking us to take blood tests for, like hepatitis C, HIV. If it is accidentally wetted, in fact, the action of soap gets enhanced due to micelle formation. If this is carelessly disposed, there's no problem because it has this germicidal layer. Unlike plastic, because we know viruses can survive on the surface of plastic, so it can itself, that disposed PP can itself act as a huge fomite. It is much more affordable than the costly plastic PPEs. It is non-toxic because no chemicals are used. It is sourced from, that soap is made from coconut oil, which is natural, easily available, whereas plastics, as we know, they are made from these petroleum and these products, which are fossil fuels. And in fact, coconut oil is very healthy for the skin. We did, send the later prototypes for air testing to see if they were as good as plastic PP as far as lab conditions were met in government certified labs, and they passed all the tests, and it's sterilizable by ETO. Of course, I thank all the people who've given their ideas, suggestions, and support in this collaborative journey. So now we have to keep thinking further. This is just the start. So this is very useful. Its main utility is in the COVID pandemic. Now the pandemic is wearing down. Of course, it will be useful if there are more surges of any viruses coming, but it can be used as an excellent material to replace plastic in diverse fields such as packaging materials, gowns, trolley sheets, and we can work on other aspects of this as well. I thank you very much. Not as yet, sir, because right now I'm trying to raise money. As an individual doctor and all, I've just been working on the prototype. Now we are going to do a pilot and make 100 pieces and share it with other doctors, get their inputs and all that. So.
Mics are not working.
Excellent innovation.
Thank you, sir.
Few questions.
Sir.
One thing is regarding your stabilization. Surface only. So will that have any impact?
Yes, sir, because in fact...
you were saying that we can use it in surgery maybe in future. So have you thought about that?
Absolutely, sir. There are many advantages because we used the same labs, which test when you're giving blood. When blood transfusions are done, they do bioburden studies to see if those plastic pouches in which blood is collected are safe and all. So we had those tests done on this after sterilization, and it passed all the bioburden tests in government certified laboratories.
And the soap is only a thin layer, no? Of some
Yes, so
microns.
we can vary the layer. So initially, the travelers booklets aate hain, they have soap coated on both sides. But with various innovations, we put the soap only on the internal side because seam sealing, the seam sealing tape doesn't stick to soap well. So then we modified it and put it on the inner surface only.
With body temperature, that soap doesn't get this thing, or by contamination, if it gets melt. If it becomes wet, if it becomes wet due to sweat, or if it gets soiled, then...
That's an excellent question. And in fact, there's always a tussle between safety and your comfort levels, because even the plastic PPEs, we were really sort of feeling. But this is quite light. And like I said, even if the soap gets wetted by mistake, actually it enhances its action. But it's quite a comfortable thing. If you wear it in an air-conditioned environment, it won't melt like that. And if it's accidentally splashed by you, that enhances the action of soap. So we're not worried, because micelle formation takes... No,
is
it
not
can be
reusable.
reused. So
Is it reusable
it's
or it is
recyclable.
disposable? Reusable.
Whatever the government rules are, we have to follow at that time. But all these things are, paper is recyclable, so it may be another kit can be
You
made.
will have to change the paper, no?
I beg your pardon, sir?
When you are reusing, do you have to do any modification of that?
What they do
Surface treatment, something like that.
Right, so that's excellent. So what they do for plastic PPEs, the government, they put it into first an autoclave. So the contaminated plastic PPEs, because they don't want to increase the waste, they put it in an autoclave for 3 hours, and then they put it in a microplastic shredder, and it is distributed. So this is a new invention. I mean, there's no precedent that we have to sort of this thing. So we have to advise somebody that this is what you can do.
Just on the lighter note, at the end of the day, can we use this for taking bath also?
Yes, sir. Thank you, sir. That's a lovely idea. I never thought of that. That's a beautiful idea. I will add it to the.
And how much of carbon footprint will be reduced by using this as opposed to that? Have you done any study?
Yes, sir. I
Reduction
did.
of carbon footprint by using this thing against the conventional plastic.
Calculating the carbon footprint is very difficult, but I can tell you, like the plastic PPE, the carbon footprint was enormous. I mean, they had the British people. They found that for 6 months, the amount of carbon footprint for plastic PPE was 26,000 times more than the carbon footprint of one human for 1 year. So for this, we haven't been able to really calculate, because I will have to go to the source and see how the coconut oil is extracted and all. So, but definitely it will be much less.
Thank you, madam. Excellent.
Thank you, doctor. You can collect your certificate. Next, I invite Dr. Swapnil Kotare to present his innovation, and Dr. G. Magesh will be the discussant. Dr. Swapnil. So the next will be Dr. Apurva, who presentation on topic on innovative bladeless pterygium surgery. The discussant will be Dr. Ramakrishnan sir.
Good afternoon, everyone. My name is Apurva, and today I'll be talking about innovative bladeless pterygium surgery, a non-traumatic approach. Pterygium, as we all know, is a progressive, non-inflammatory, and wing-shaped degeneration of the conjunctiva over the cornea. In India, because of the incidence of UV rays, the risk of pterygium has increased a lot in the recent past. Pterygium excision can be done by all the ophthalmologists, may it be a retina surgeon, a glaucoma surgeon, cornea surgeon, or a cataract surgeon. So the need to know about the pterygium surgery is very important to provide good post-operative cosmetic results, because pterygium surgery has been now moving towards the cosmetic approach. The pterygial excision techniques available are bare sclera technique, amniotic membrane grafting, CAG with sutures, and CAG with fibrin glue, which has decreased the incidence of recurrence to a bare minimum. The pterygial head removal techniques are mostly associated with blades, that is the beaver knife, 26 gauge needle, scalpel blade, diamond knife, or a crescent blade, which may be traumatic to the corneal tissue. The complications associated with the pterygial head removal are reduced wetting, retained tissue, injury to the Bowman's membrane, irregular dissection plane, or poor cosmesis. So to deal with these complications, we have come up with two atraumatic techniques for pterygial head excision, that is ptery snip and ptery peel. In ptery snip, it is a suture-based pterygium removal in which a 26 gauge needle is used to place a superficial epithelial incision along the pterygium head. The neck of the pterygium is excised and a cyclodialysis spatula is passed below the pterygial tissue to make a clear dissection plane. The 406 suture is passed below it and is held with a muscle clamp and a tissue holding forceps. With the counter traction by the cyclodialysis spatula, swinging motions are applied centrifugally to separate the tissue from beneath. The disadvantages of this technique, whereas, are two people are required for counter traction, and abnormal plane of dissection can lead to retained tissue post surgery. The second technique is TERI peel, which is a peel-off technique of the pterygeal head removal, in which a superficial epithelial incision is placed along the pterygeal head and the pterygeal tissue is excised along the limbal border. As similar to the conventional method, the pterygeal tissue is then held with a muscle clamp forceps and for good hemostasis and good grip of the tissue, and with centrifugal swinging motions, it is removed from the corneal tissue underneath. The residual tissue post this technique is so less that it can be managed with a simple polish of the burr. The disadvantages of this technique are a customized instrument for grasping is not available for the pterygeal tissue. The lack of proper counter traction will lead to globe traction, which is difficult for us to manage, and harder grades of pterygym are difficult to manage with this technique. But these are the two pterygeal excision techniques that we have come up with, that is TERI snip and TERI peel. In this era of recent advances, the need to eliminate the use of sharp instruments is of utmost importance for better post-operative cosmesis and visual acuity, and the chances of complications like retained tissue, injury to Bowman's membrane, and poor cosmesis can be eliminated with only a simple use of suture or a muscle clamp. Thank you.
Thank you, Dr. Burba, for presentation. And of course, the idea is good. It's bladeless, because now we are doing all the surgeries with bladeless only.
Yes,
but
sir.
the technique what we witnessed done by you is so much more traumatic to the corneal and conjunctival tissue than what we do with the normal knife.
Yes, sir.
No, after the you have done this pterygium, no, with
Yes, sir.
the surface is not so smooth.
Sir.
So then you have to use burr and all these things. But when you use a 15 blade normally, you can have very smooth, very very regular, homogeneous surface. And also the time taken was very, very less. And here you need two people to almost fighting for each other. Something like that. That's what I don't know. But normally what we use is a 15 blade and a nice dissection of corneal bed without any debris or any irregularity of the corneal surface. Then put the autograft and the glue. That's a fine technique. But how many surgeries you have done with this technique?
So it was mostly for the moderate grades of cataract, where the addition to the Bowman's membrane is not much, where the scarring is not much. So it was easier to remove like that without any residual tissue. Otherwise, the rate of recurrence that we have seen with these techniques is very less. Like hardly any patient has gone for resurgery with these techniques. That is what we have observed.
It's not depends upon the technique
No,
what
yes,
you
sir.
use, whatever technique you use. So it depends upon the tissue that ability after the surgery. That's are you using any mitomycin or anything?
Sorry, sir?
Mitomycin used in these cases?
No, sir. No,
You
sir.
are using conjunctival autograft. No?
Yes, sir.
Yeah, okay. Yeah, the thing is bladeless. That's a
Yes, sir.
thing. Otherwise, I don't find any advantage. Yes. Any comments?
Yeah. Sir, can you give the certificate to her?
Can you use this technique for a recurrent pterygium?
So we have tried for recurrent pterygiums also, and it has not been a problem. The only thing is that the dissection plane has to be clearly dissected in the start of the technique only. If that dissection plane has been properly dissected, then we have not problem.
Dr. Kartikeya Singh is there. Please. Who is the discussant? Discussant Dr. Rishi Swarup.
Good afternoon, everyone. I'll be talking about my innovation in SFIL of haptic cut modified SFIL. So why are we cutting? Because in a normal routine SFIL, which we were doing with Yamane technique, there were a lot of pseudophacodonesis, there was tilting. If there was not good vitrectomy, then CME was also there, and occasional dislocation. So what do we do here? I'll just show you in the videos. Disclaimer is there, the videos are high speed to accommodate more. This is my first case. So this was a 58-year-old male with traumatic nuclear shock. Ladies and gentlemen, showing not very now. And take the other side out. Six by six. With just 0.75 cylinder once again. So the post-op of that, and the origin of idea was a dislocated Yamane, which I saw in my body. In this case, I thought it same IOS. So my innovations are just like always mind the gap, because if you have a gap, then it forms a triangle which snugly fits inside your needle track, and the guard to keep the other side haptic intact, because if otherwise someone is required to hold it, and the haptic cut from the original idea of dislocated SFIL which I had in my OPD. This is the master chart of almost 15 patients I have done already. And if you don't have a Bowie, then you can also do
Yeah, check. First thing you talked about guard, right?
Yes.
That was innovated by one Dr. Prabhu Bhaskaran. I am just saying he has already published it as ex-nit technique. Yes. Okay, let us give the credit.
Yes.
And even cauterizing the haptic is already there actually in the literature. It's not new.
No, I'm just cutting the haptic, sir.
No,
I'm cutting the haptic. I'm not cauterizing the haptic. I'm cutting the haptic to make it more stable. because when routinely done SFIL by Yamane technique, there's a lot of dangling because there's an extra haptic inside. So you see a lot of tilt, you see a lot of dangling. Sometimes even with the trivial trauma, the dislocation is there. And when the haptics are extra, they are much more toward the outside under the conjunctiva. So you see sometimes a lot of granuloma for 2 to 3 months. So when I'm cutting it, it is getting snugly fit inside the track, and the granuloma, all these problems are gone. So that is my innovation, to cut both sides 2 millimeter to make it more stable. And the refraction stability is really good with my technique. I've done already 15. So
Yeah.
I'm getting
Just I beg to differ because we use Gabber's technique, the original innovator. We have been doing for the last 16 years. But whenever the haptic is stiff for more than 2 millimeters, the chance of dislocation over a period of time is more in cases where there is a shorter haptic. So you need to have a longer follow-up to say that it is...
almost 1 year follow-up I have, sir.
Sorry, just one thing. How does cutting the haptic helps in holding the lens on the sclera? You said the dislocations are happening.
No, sir, because once we are cauterizing it and then sending the haptic back, so both the sides there are extra haptic length which is there inside the eye. So the dangling, pseudophacodonosis and all I saw in my OPD. That's how I started cutting it and placing it inside.
That should have been measured before cutting and after cutting. That should have been measured.
Yes, sir, we are doing that.
Dislocation is more to do with how you create the flange.
No, not about dislocation. Just about decentration, just about pseudophacodonosis, and also the tilting. Because of the extra haptic, we saw a lot of tilting inside, and also reported by a few other colleagues of mine that when we are doing Yamane, we are seeing a lot of tilting. So we are like doing it at 3-4 centers now, and
can I ask one thing? The tilting, if you are exactly in the same line and exactly the thing, there is no tilt.
Yeah.
Improperly done Yaman.
Yes, sir.
It can be improperly done. Many things can be improperly done.
agree,
That's
sir.
okay. And another thing is, how many millimeters do you cut?
2 millimeters, sir.
2 millimeters.
Yes.
That means the 2 millimeters which is from the tip. And then how many millimeters do you cauterize?
Other 2 millimeter.
Again 2 more millimeters.
Yes, sir.
So, but if you push it back into the scleral the tunnel, if you have made 2 millimeters of intrascleral pocket,
yes, sir,
then how many millimeters is left now?
Around 3 to 4 millimeters is left now, sir. There.
See, when we do a regular gabber, as he was telling,
yes, sir,
when we externalize it from 2 millimeters without a track, you don't get more than 2 or 2.5 or 3 millimeters outside. If you have a proper track.
Right,
So
sir.
when you don't have a 2 millimeter track, that is when you get more haptic out.
Right.
When we externalize regularly from a stab entry, it comes out and not more than 3 millimeter comes out. Not more than 3 comes out. So if you have
almost
made
4 to 5 millimeter comes out, sir. If you like snugly fit.
no,
fit
that
out.
is when you are stretching. You can stretch out a bend haptic like this, and you will see a lot of it coming.
Right, sir. That's what I'm stretching it to make it more stable.
And that's what I'm telling. If you stretch it, you will see that a lot of haptic comes out.
Right.
But it is not the optimal position of the haptic to be stretched flat like this. The optimal position of a haptic is to remain in its normal, regular orientation to avoid tilt and torque. So if, according to me, if it is cut very short and if it is kept vertically straight like this, there is a traction possibility on the sun rather than being on a very
It's not very
relaxed
straight,
kind of
sir.
thing.
It's not very straight. It's not very straight.
It's not very straight, but
laxity
yeah,
which was
understand.
there,
I understand. We understood the whole thing, but only thing is my personal doubt. Because a lot of haptics don't usually come out when you exactly 2 millimeter behind and you're taking out through the sun. So if you stretch and take out too much and cut 2 millimeters and then flange 2 millimeters, losing a lot of haptic. That's what I felt.
Also, one more thing, you're cutting it as an approximation. It's not an exact. You're not measuring it.
Yeah, I did not show that measure just in
the
the
haptic
time
is an
crunch.
exact size, So if you cauterize that, you're more likely to be more symmetric.
I'm putting a mark in the starting itself before taking the lens. I don't have there was a time crunch, so I did not show.
Got it. Okay. Thank you.
Thank you.
Certificate. Dr. Jitendra Jethani, Dr. Abhinav Dhami, So he's going to talk on outcomes and comparison of retinal autograft using Finisci flex loop in failed macular holes. And the discussant is Ellen Kumar.
Hi, should I start? Hi, good afternoon. So I'm going to be talking about the outcomes and comparison of the retinal autograft using the Finisci flex loop in failed macular hole cases. So we know that the iLM peeling has become the gold standard for doing any macular hole surgery, and just a plain iLM peeling guarantees 80% success rate. And if you do the conversion of the iLM peeling with the inverted flap technique, we get a 96% success rate. But we still have about 4 to 5% cases where we do fail. And some of the techniques that we've been doing for these failures is we regraft reuse the iLM, we use autologous products, anterior capsule of the lens, fibrin glue, or we use autografts as the retinal or the choroidal. So our focus is going to be on the retinal autograft, that is for using managing these failed macular holes. Till now, we have been introducing localized retinal detachment and using intraocular scissors to obtain a retinal autograft. So our first innovation was that we published it also. We used the Finisci flex loop, which is being used to scrape the iLM. We used it to obtain the retinal autograft itself. This was a retrospective study design, and we had all patients with failed macular surgeries or in a patient with any subtotal retinal detachment with a macular hole. So primary outcome was to evaluate the anatomic and functional closure of the hole with the retinal autograft. So this is any macular hole, this is the OCT picture, and this is the autograft picture. And then we do the surgery, we do a cautery, and just with the Finisci flex loop, we scrape the edges of the autograft to obtain one whole piece of the retina, which we use to fill the macular hole, as on the OCT picture on the right side. So our results, we had 8 patients, 75% of 6 eyes were just plain autographed eyes and 2 cases were with retinal detachment. We observed a post-op macular closure of 75%. When we looked at the post-op visual acuity gain, we saw 1-line improvement in all of our cases, which was statistically significant. And the only complication we saw at 6 weeks was the post-operative was the graft shrinkage, which happened about 2 eyes. So knowing this, that our technique was working, we compared our technique with the pre-existing intraocular scissors and with the retinal punch that was defined by Dr. Rupak Roy to compare our results with that. And this was again a multi-centric analysis of all the failed macular holes. 6 surgeons were involved. The primary outcome was same for analyzing the closure of macular holes and the reattachment of the retina. And secondary outcome was to see if there is any restoration of the foveal contour or any integration of the graft of the inner and outer retinal layers on the SDOCT. So in results, we saw we had 22 eyes. We had ARG done in 16 eyes and ARG and RD done in 6 eyes. And the preoperative diameter of the macular hole was around 1100 microns. And we used gas in 15 cases and oil in 7 cases. With all these cases, we obtained a macular hole closure about 72.7%, and visual acuity was actually increased to 81.8% of these cases. So, and when we compare these results as in comparison of visual acuity in all 3 scenarios, we saw that the Finisci flex loop and the scissor was able to give us a good post-op visual acuity, which was statistically significant as compared to the retinal punch. But when we come at the restoration of the outer retinal layers, we realize that the retinal punch was giving a much more greater restoration of the outer retinal layers rather than the Finisci loop and the intraocular scissors. And the complication was equal in all the groups. We had a graft shrinkage in all 3 groups. Only a dislodgement of the grafts was noted in a case where oil was used and there was a complete graft loss. So in conclusion, ARG can be an effective surgical application for large failed macular holes with or without retinal detachment with good functional and anatomical outcomes. Statistical visual gain can be expected after autologous retinal graft, and our study concludes that both Finisci loop and intraocular scissors offers good retinal outcomes, and retinal punch was associated with more functional outcomes and more graft shrinkage. Thank you.
How many cases you said 8 cases you did this?
So initially first study was 8 cases.
That first picture, no, that it you are talking of this 1100 is
the second
minimum
one,
linear, second is with RD.
No, this is the one just plain macular, failed macular also.
Failed macular.
The RD ones we didn't really get to measure the macular so much.
Okay. So that is the second. The first case you that showed, no, that macular hole has histoid changes and that configuration. We just with FA and
so we already tried.
Close.
So he was already operated thrice somewhere else.
That one.
Thrice was already operated. 3 ILM filling was done.
Because we did some analysis of 700 macular holes. Just usual standard ILM peeling closes 80 to 85%.
That's why we already had 3 cases. Then we thought
that is a failed one. That's
a failed
one you
one,
showed. Okay. Unless there is a randomized trial, no. No, you said you are using finesse loop.
Yes, sir.
But in your video, it is not shown.
Yes, it's shown, sir.
Oh, okay. Do you use a PFCL when
No,
you're...
sir.
No.
No, sir.
But in case if the retinal graft flips, instead of seeing the
So
outside world, they will start seeing the brain. How will you prevent that?
No, sir, we actually do a cautery around the autographs, so the cautery mark is very much visible. So we just gently drag with the forceps, we just drag it and put it on the macula itself. We don't make any intraoperative changes at that point in time, so that the fluctuation will cause the graft to move away somewhere.
Okay. The last question. What is the innovation in this?
So the Finex Flex fluid, it's not been used for obtaining retinal autograft. We are the first ones to use the Finex Flex fluid for obtaining retinal autograft. As per the Alcon, they only use it for iLM peeling. We've been using it now. We have about 12 cases. We've been using the Finex fluid with no localized retinal attachment and just autograft.
Dr. Abhinav, for non-retina specialist, you should have told us what is Phoenix Plus. We have no idea.
It is used to peel the ILM also.
Just to scrape the retina.
Just to raise the
ILM
edges.
layer.
It's a brush. Instead of scratching our back, we can scratch the retina.
Very good sense of humor, Naresh Babu, sir. Always typical Naresh Babu.
Thank you. Okay. Any more questions on this? Or he can receive the certificate, Dr. Mahesh, please. So next we have Dr. Jitendra Jethani. Will present on measuring peripheral refraction.
Good afternoon, everybody. I think I'm the person who's stopping everybody from going to the lunch, right?
Yeah, I would request Dr. Suhas Aldipurkar to be the discussant for this, please.
So this was one patient who I would be presenting a small case, and I will be showing how it's not moving. Slides are not moving. Okay, now it is moving. Okay, so this is a story of a young boy who presented to us with simple myopia. The patient presented post-COVID in 2021 March, and the refraction was minus 1.25 and 1.5. We did the cycloplegic refraction, we did axial length, we did near point of accommodation. All the other tests were normal. Axial length was noted down. We called the patient after 3 months. That is a normal protocol for myopia control clinic. And the patient did not come back after 3 months. Once they get glasses, they can see 6/6. They come back at their own time. So patient came back after 6 months, had a progression of myopia. We started the patient on low concentration atropine. So far, so good. January 22, patient came back with a progression of myopia. So typically what we do is that we have learned from our previous studies that now we increase the frequency to twice a day. Patient came back on July 2022. Again with a progression. Now here we were stuck. We thought that we thought we need to do peripheral refraction. So the problem statement was how to do peripheral refraction. Now the answer is there is open field autorefractor. We don't have it. The cost is a hindrance. All of us have our own 3 or 4 autorefractors. So this is typically around 12 to 14 lakhs, and we did not want to invest in this. So we thought that we will try to find out an innovative device. I was sitting in my OPD, I drew this with my own hand, and then I tried to make a 3D print out of it. So this was the final device in which we could do the peripheral. So this is basically a handle which has been fitted on the top of the retinoscope with 2 arms. All these have been measured. So at the distance of 67 centimeters, you can get around 22 degrees temporal, 22 degrees nasal. And how do you get it? You get it like this. You ask the patient to look on these 2 fixing targets. Patient can turn his head or patient can turn his eyes. We have a old research paper published in 2008 saying that whether you turn your head or you turn your eyes, it doesn't make a difference in peripheral refraction. So that paper is just to tell that if patient can turn his head, normally we tell the patient to look straight and turn the eyes towards that particular target. You can see whether he's turning his eyes and do the refraction, and mentally you can make up what is the refraction, what is the peripheral refraction of the patient. So this, how did this make an impact? Now we all know that peripheral refraction is and has been responsible. Peripheral retina has been responsible for progression of myopia. Now there are specific glasses, DIMS, HALT, Mykido. These are available depending on if there is a peripheral hyperopic refraction. So this is a wonderful article, the first article which was done on. So what they did was they ablated the Macau monkey's fovea and they tried to prove that peripheral retina is responsible for progression of myopia, and this is the refraction of our patient, the peripheral refraction, and we prescribed the glasses to the patient. It was a stylist which has a peripheral defocus, and in December 22, this was in July 22, so we prescribed in July 22. Patient came back with minimal increase in power, so he is still on atropine twice a day. Along with that, we have prescribed stylist. So peripheral defocus lens would reduce the hyperopic defocus and bring it and make it more myopic. So this is one of the first devices across the globe which has been used for peripheral refraction. This is our algorithm as to how we treat a myopic patient, nothing to do with peripheral refraction. Just that, just to complete the slide. Thank you so much. Any questions we can say. Thank you, sir.
Indeed, it's a good paper.
Thank you, sir.
But just tell me, how do you once you know the peripheral refraction, how do you incorporate it into the spectacle?
Okay, so a peripheral refraction of more than 0.75 hyperopic, 0.75 is thought to be one of the culprits for progressive myopia. So typically in a myopic patient, so there have been multiple articles where they have, with an open field autoref, we have given this device to Sumita madam. They have an open field autorefractor. They are trying to do a validative test whether it is useful in comparison to open field autoref. But if there is a hyperopic refraction in the periphery, the theory is that the focus is not on the retina and behind the retina, and that is what propagates the eyeball to progress further. So once you have a peripheral refraction which is more than 0.75 in the periphery, we can give these peripheral hyperopic lenses. Right now, the problem with prescribing DIMS or with HALT lenses is that we actually do not have a peripheral refraction device. So we are just giving it because we want to give it. I mean, because there is a myopia progression, so we are giving a myopia control lens. The myopia control lens works on the principle that there has to be a peripheral hyperopic defocus. So that's how it would make an impact.
How big has been your study, or it's just...
No, so this is just we have not done a study. This is just the device which we have made, and we have tried to see the patients. Now we are putting it in the testing phase. We are comparing it with an open field autorefractor, whether this serves as good as a open field autorefractor.
Nice one.
Thank you, sir.
Congratulations.
Thank you.
Any other questions from the judges, or we can? So, okay. So if no questions, then thank you very much, Dr. Jithani.
No, I have not bought it. So I said we have given it to Dr. Sumita Agarkar. She is a senior pediatric ophthalmologist at Shankar Netralaya. They have got an open field autorefractor.
You tell.
They will be doing it, yes.
Who have not come? Okay, so you have to receive a certificate. You have already got a certificate, sir? Okay, he has got it, sir, already. It's presented earlier. So he has got it. So I think, thank you very much. It's time to come, and we finish the prelims here, and we'll come to the finals at around 2:30. The results will be announced in the WhatsApp groups, and don't worry, whoever all the winners will definitely be called by the ARC office in case if you don't see the result. So I request all the judges to please hand over the mark sheet to Velu Murugan, one of the efficient boy of our ARC team, as a office from the ARC office. And I would like to thank our moderators, Dr. Meenu Mathan and Dr. Tamil, and of course the judges who have taken most precious time to come here. And thank you, Naresh sir, Ramkrishna sir, Dr. Ilan, Mahesh sir, and thank you, Dr. Rishi Swaroop, Dr. Suhas sir, and Dr. Bhide sir, and all the expert panel judges, and of course the delegates who have been here, and most importantly the participants. Thank you very much for participating, and we'll see you back very soon. Thank you.